introduce Gilbert Whitton, who will be talking to you about cannabis and stimulants. Now, when he finishes that first part, which he's going to be giving you some information, then he will be doing a role play, and then you guys are going to do a role play.
Thanks, Hester. So that's working. Good. Okay. What did people think of the role play that Jenny organised with the medical students?
Very good.
Fantastic job.
Fantastic. Very good. Okay. Can I flesh that out a bit more?
According to what you call the role model, we need to bring the patient quite a few times.
You need to get the patient in quite a few times. Hard to do in a quick general practice consultation. Yeah.
It is frustrating for both sides.
Frustrating for both sides because of time. Yep.
Dragging them back.
Patients in a hurry. You're in a hurry. Yep.
That's right. No, dragging them back to.
And dragging them back. Yep.
It's more. Second thing is also the time consuming.
It's time consuming.
For the patient and for the doctor.
For the patient and the doctor. People agree with that? Francis?
One of the things is that I think most of us who are in the opiate replacement therapy, we actually do this motivational, but actually...
I know you do because you prescribe methadone and buprenorphine, but I actually was talking to a GP earlier who...
Yeah.
Thanks, Hester.
I think side effects have to be described to the patients. We have to give them some, not just treatment, but explain why we give them the treatment. What is the side effects? And this is most important in this part. This way we can help them to stop. And if you don't describe the side effects, they go home, they can come to you, but will not be effective.
Yeah, thank you. So one of the comments that was made was that we do this anyway. So, but it was useful, I think, for some of you, I heard over morning tea, to get a framework within which to do things. Did people find that the framework helped? Now the framework which Jenny presented was didn't actually apply to any particular drugs, did it? Any particular substances. So now we're going into talking about some of the specific drugs. But do we think that, for example, talking about cannabis and stimulants is different to talking about alcohol and cigarettes? Yes, no?
Yes. Some difference.
Some difference? There's a conspiracy about illicit drugs.
It is putting some barriers. Alcohol, smoking, body weight, whatever.
Yeah.
It's a little bit more easy to talk about. When you're coming to the drugs, there is a barriers between both parties.
So a little bit more easy to talk about the cigarettes and alcohol than it is about illicit drugs. Yeah. But what about the role play? What about our wonderful medical students and in the role play? So what were the substances we were talking about there? Ice, yeah,
Ice.
And?
Alcohol.
Alcohol. Was the doctor different when she was talking about alcohol to when she was talking about ice? I didn't get a sense of that, did you? What I liked about it was that the doctor took pretty much the same approach to the ice problem as she did to the alcohol problem. And to me, that was one of the key things from what Hester was saying right at the beginning, is that the approaches you use, whether you're talking about alcohol, whether you're talking about cigarettes, whether you're talking about illicit drugs, or for that matter, whether you're talking about physical activity or you're talking about diet, the approach is the same. Motivational interviewing works, whatever it is you're talking about, whatever the behaviour is you're trying to look for change in. And the 5 A's, likewise, is an approach you can use to no matter what the problem is. So I'm going to talk about cannabis and stimulants, but the real thing I want you to think about is this any different to talking about, say, cigarette smoking? So if I can drive this. Okay, so there's just some data, and Hester presented some data at the beginning just about drug use. Does that give you any thoughts about, does it surprise you? Do you agree with it? Does it make you think about your practice? So the drugs I'm going to focus on are here, the amphetamines, and here, cannabis or marijuana. Is that what happens in your practice? I'll get you just to think about that, what the relevance to that data is. Okay, so Jason's 38. He presents to you as a new patient for general health testing. You discover that Jason had episodes of risky behaviour and he discloses that this may be due to being out of it. How would you approach this? Sorry?
History into that.
More history.
Yep.
So how are you going to do that?
Yep. Ask 5 A's.
Ah, very good. 5 A's. Excellent. Yes, yes. Yeah. Good. So we need to take a drug history. Now, the way I think about a drug history is that there's a sort of hierarchy. I think, as you've all said, it's quite easy to ask patients about whether they smoke, whether they drink. Do you ask them whether they use cannabis? Do you ask your patients whether they use cannabis? Do you ask all your patients? If they have taken drugs.
Yeah, if they have ever used it in the past or, yeah, something similar around the lines, I guess.
Yeah, but how do you know?
Maybe we can
Without,
start.
no, go ahead.
Maybe we can just start asking, like, when we start, do you smoke, do you drink, do you take any drugs?
Yeah.
Yeah, do you take any drugs? When he comes up to it, then we can further inquire what type of drugs he's taking and then what's the use of his drug.
If the patient smokes cannabis and you ask that question, do you use other drugs? What do you think they'll say?
It all depends if they are using or not.
Do you think? I would like $1 for every time that I've asked a patient, do you use drugs? No. Do you use cannabis? Oh yeah, I use that. So I want to argue that because of this data, it is the most commonly used illicit drug. About more than 30% of the population have used it and 10% are currently using it. And if you look at health populations, the rates are even higher. This is the general population. So I want you to think about whether just asking a general question about drugs elicits whether somebody uses cannabis or not. Okay? My approach is to ask these questions and to keep going as long as I'm getting positive answers. So, do you smoke? Yes. Do you drink? Yes. Then I ask specifically about cannabis. If they've never smoked cigarettes or they don't drink alcohol, I probably will just ask a general question. But while I'm getting positive answers through this hierarchy, I keep going with specific questions. Because I think if somebody smokes cigarettes and someone drinks alcohol, the chances of them smoking cannabis, again looking back to the data thing, is actually pretty high. And the chances of you getting a positive answer if you just ask a general drug question is actually pretty low, certainly is in my experience. I think you do have to ask specifically about cannabis if you think there's a reasonable chance that the patient might have used cannabis. You want to get them to be honest about that. And then you can ask about other drugs. Clearly need to ask about problems, and of course the question of injecting is important. People agree with that?
Hang on.
Actually, we asked most of the question, but that bottom one is very rare. We ask the patient whether he's injecting a drug or not.
Yeah. So again, I agree with you that the chances of them injecting drugs are pretty low, especially if they've not used other drugs. But again, I think if you use this sort of hierarchy and you're still getting positive answers, so if they have used cannabis, if they have used other drugs such as amphetamines or opiates or whatever, I think a question about injecting is relevant. Again, I'm happy for people to disagree. There's no right or wrong answers in any of this. Let's get discussion going. I'm just trying to tell you my approach and my feeling about these things. Yes, Jenny?
I was just going to say, one of the other groups of drugs that often doesn't...
It's very hard for people, sorry, it's very hard for people to hear.
One of the other groups of drugs that often doesn't come up in that standard questioning, in my experience, is pills.
Yeah.
And often sort of asking specifically about, do you use any pills?
Yeah. And we are doctors after all, so we can ask about medications, and of course the addictive medications are a major concern, aren't they? Benzodiazepines, opiates, prescription opiates, and the like. So That's the other. So yes, legal drugs, illicit drugs, prescription drugs, or even over-the-counter drugs are really important to ask. So that's a very useful framework to have. Yeah.
Hang on.
It's about time. We spent too much time.
Hester's getting very fit.
Yeah.
Sorry. No, I was just thinking, do you use drugs? Well, not really, I don't, but I have done. So I tend to ask, have you ever used? And then, obviously.
Yeah. Good. So what about cannabis specifically? Well, it is the most commonly used illicit drug. There's evidence that it is associated with a range of health problems, and some of the best evidence is for academic performance and early school leaving. And one of the concerns is that the age of initiation might be getting younger, or certainly had been, and that's causes potential problems. So how do we actually ask about cannabis use? So firstly, I think you've actually got to ask specifically about it, as I've said, and I think we need to ask about amounts, about last use, frequency of use. One way of thinking about it is how much money they spend on it, and time of day. One of the key questions I found, my whole approach to cannabis changed when I started working in the juvenile justice system. Kind of up till then, I actually thought, as somebody who's dealt a lot with people with severe alcohol problems, somebody who's dealt a lot with people with severe opiate problems, I actually thought cannabis was a bit of a soft drug in sort of health terms, or at least in my practice. And as I say, I changed my view about that when I worked in juvenile justice. And I had to get used to actually asking young people about their, so, you know, this old bloke coming into the juvenile justice system, having to ask these young people about their cannabis use. And I must say I was pretty nervous about it. I didn't quite know how to ask. I didn't quite know how they were going to respond. And I didn't quite, because I don't know much about cannabis, and I suspected they did, I sort of felt a bit out of my depth. But I found one of the best questions to ask to try and get a sense of whether they were dependent or not on cannabis was, what time of day do they first use? Because many of them said it was the first thing they did when they wake up in the morning. And it's almost, one of my colleagues says, it's almost like they spent more time sucking on cannabis than they did on oxygen. You know, they'd look for cannabis first thing in the morning and then they'd be smoking throughout the day. So to me, that's dependence. I mean, I used to think that you couldn't actually be dependent on cannabis, but I discovered, certainly in the juvenile justice system, that there were many young people who were just smoking cannabis all day. And as I said, the most useful question I found to ask them was, what time of day do you start? Because that gave you a sense of how dependent they were. Clearly, we ask about problems, periods of abstinence, and what led to relapses, trying to understand some of the things that are going on for them and how you're going to help them, and previous withdrawal experiences. So there clearly are whole sets of effects from cannabis, but I much preferred the approach we heard before about getting the patients themselves to talk about it. So a bit like the role play that we saw, instead of starting to just sort of list the terrible things about alcohol, the terrible things about amphetamines, actually getting the patient to tell you what their sense of it, the good things and the bad things about what they're doing are, is more useful. But these are just some of the things to bear in mind that could be problems, and that therefore if you're not getting much of a response from the patient, asking them about some of these problems. Does that make sense to people? But be open, and of course the notion of being able to get patients back again and addressing them again. Do I see a hand? No. Okay, and one thing to remember is this concept, this syndrome of cannabis hyperemesis. Sometimes you do see patients who smoke a lot of cannabis who get this refractory nausea and vomiting, and they talk about compulsive bathing and showering to deal with it. And sometimes people think that that's withdrawal, but actually it is an effect of heavy cannabis smoking, cannabis hyperemesis, and it can get better once they stop smoking. Okay, anything more on cannabis? Yeah.
How long after having cannabis can you drive?
What do people think about that? Sorry?
36 hours.
36 hours, you reckon? So I think the question, there's two questions. There's the question of when is it legal and when is it safe? And I actually think they're different questions, because with if somebody is tested, they can have cannabis in their system long after they're actually affected by it. So I think the effects last a number of hours, but of course the cannabis being in their body, if they have a saliva test or a urine test, is going to be sometime after. People agree with that? Does that answer your question?
Another question here.
Yep.
And sometimes the people are coming to us and doctor prescribes. Yeah. Okay. So recently, some of my patients asked me, doctor prescribed some cannabis for me.
Yeah.
So how will deal with this patient?
How do you deal with the
Yes.
Sorry, can I suggest that medicinal cannabis is out of scope?
Yep.
Catch up with Gilbert or some of the other experts in the break.
Yeah.
Thank you.
But I think the important issue is that the view about cannabis is changing in our community because of the medicinal cannabis debate. But I would say that it doesn't affect the fact that cannabis is still a recreational drug and is still illegal for most people in most circumstances in Australia, and still causes all these health problems. So the health problems and generally the legal problems for most of the patients we're dealing with are still the same. But yes, the fact that cannabis is used can be used as a medicine, and that whole field is changing, is another issue, I think. Okay. Okay. Anything else? Yep.
Yeah, the question, the patient comes and usually he smokes for 4 to 5 times per day cannabis, and he or she won't immediately quit. Can we stop immediately, or we have to tail off, or how we can manage that? Or we have to send it to drug and alcoholic unit?
So managing withdrawal, there's a set of substances, and if you look up the guidelines, you can see the different withdrawal syndromes that occur, and there's always an onset and a duration of the different withdrawal syndromes. Of those drugs listed there, which one's the withdrawal from which is the most problematic in medical terms? Ice, amphetamines, is that true? So amphetamine withdrawal is worse than all the others, is it? Shaking your head, so which is the worst?
We've got somebody over here that's got an answer.
Yep.
Sorry. Who was it? Somebody said it.
Alcohol was said here. Was that what you were going to say? Of course you were. Yeah. So in health terms, obviously much withdrawal from all these substances can be non-problematic, but if any withdrawal syndrome is going to go bad, it's going to be alcohol. Okay? People can get seizures, they can get disoriented, confused, be delirious with alcohol withdrawal. It doesn't happen with any of the others. So if we come back to cannabis withdrawal, like many of the others, like nicotine withdrawal, for example, I mean, would you admit someone to hospital for nicotine withdrawal? So I think if you think about cannabis withdrawal as being on the same level as nicotine withdrawal, it is real. It is something that makes the patient want to keep using, so we shouldn't downplay it. But on the other hand, we shouldn't also be admitting people to ICU because they might be experiencing cannabis withdrawal any more than we should if they're experiencing nicotine withdrawal. Yeah.
Excuse me, Gilbert. I thought I'd just emphasize the fact that of all the drugs that human beings consume, cannabis is probably the only one that is not a single drug. Like nicotine is one chemical, alcohol one chemical, amphetamine is one chemical. But cannabis is a complex drug, and it's got two things that you should consider. The one we're talking about with this problem of addiction refers to the THC. The cannabinoids, which is now a subject of great review for medical cannabis, doesn't have that much of a psychoactive experience. And I think people should consider this distinction between cannabis as the only drug, as far as I know, that human beings consume that has got this effect. The other thing about cannabis is the only drug too, it's lipophilic and stays in the system for a long time. And that's the importance of the long-term effects.
Thank you, Nino. That's fantastic. Quite right. Yep.
Gilbert, another thing that I'm a kid of the 60s of Woodstock and Jimi Hendrix and all that. So I'm just, one of the things that over the time in Australia, the effects of the natural grown cannabis in regards to hydroponics. And it seems to me in my observation that most of hydroponics have a detrimental effect on the CNS system. So is that?
I think there's a lot of concern that cannabis today is stronger than cannabis past, but yeah, there's also a counter argument about that as well, that can be overplayed. Okay, so it's absolutely true. Cannabis is a natural drug. It is also a drug that has a number of constituents for it. Another broad area of drug is the stimulants. So what stimulants do we know? Thank you.
Nicotine, caffeine.
Nicotine, caffeine. Any others? Amphetamine. Cocaine. Very good. So these are the amphetamines. This is what they look like. So amphetamine. This is amphetamine. This is methylamphetamine, which just has the additional methyl group on it. So it's just sort of slightly different to amphetamine. And the different ways in which it comes, it can be snorted, it can be smoked, it can be injected. Obviously, that's a concern. More and more concerns about the crystalline forms, which are what are called ice, and less so much than the powder, which used to be called speed on the streets. And of course, if there is a change, it's a shift to the more crystalline forms and a shift to more problematic use. So it's not necessarily that we're seeing higher rates of use. What we're seeing is more problematic use, possibly in some groups. So how do we ask about amphetamines? Again, all the same principles we've used before, and but if you want to know some specifics, some of the sort of measures of points and grams are there, and again, you can always translate it into how much money they're spending, as you can with any illicit drug. Obviously ask about smoking and injecting. When did you last use, again, if you're concerned about withdrawal, and have they experienced other withdrawal types? So we've talked about that. There's some other relevant questions, obviously. Okay, so this is Jason. Again, what are our thoughts about him? What are our thoughts about him? Yeah. So again, I think it's about trying to work out for him what the problems are, isn't it? And of course, it's not always about the drug in the media, is it?
The most use is probably alcohol. Sorry. Looking at it, probably the most of the use is alcohol.
Yeah, and remember he came because he was concerned about being out of it, wasn't he? So what's he more likely to be out of it on? Alcohol. Yeah, that's right. Obviously, it can be a bad combination, alcohol and amphetamines, but sometimes it's the common problems which are more concerned than the problems you read about in the media. Okay, so there obviously are a range of places you can get help, and they're all listed there. I work in South West Sydney Local Health District, so I'm going to talk about the services to help you in South Western Sydney. Tao Lam's talking, I think, after lunch, and she will talk about Western Sydney local health services. But these are the different groups that can support people with amphetamine problems and drug problems generally. In South Western Sydney, we have an intake line that patients or you can ring up to refer patients. And the most exciting thing about South Western Sydney is that we now have an actual GP support service. Michael, are you up there? There you are. Michael, can you stand up? Thank you. So Michael Estepa with Jenny James, who you've heard from this morning, are running this service. And on this phone number, you can get Michael, a clinical nurse consultant in drug health. What hours are you operating, Michael? Monday to Friday, 9 to 5 for GPs in southwestern Sydney. Yeah, thanks, Michael. Good. And Michael will tell you about, again, our intake line, our drug and alcohol services, and then another pamphlet we've got is a whole list of drug and alcohol services throughout southwest Sydney and services in other areas that your patients can access. Very good. Hi, Nathan, I'm Dr. Whitton.
Nice to meet you.
Nice to meet you. What's brought you in today?
Oh, look, I mean, I'm not coming here because I want to. My girlfriend and my mum are a bit concerned. I had a sort of a nasty episode after taking some ice last week. And they want me to come here and they're really worried about me. So I figured rather than let them keep pestering me, I'd come in and have a chat.
Good, thanks for coming. So you don't feel as concerned as they do?
I mean, I don't know. I had this nasty episode, but I don't. It's hard. I enjoy it when I use it, so I sort of think I'm not. You know, I think they're much more worried. Mum's worried that I'm sort of going to fry my brain and get kicked out of uni and things like that. So I'm not that worried about it, to be honest.
So you're at uni?
I'm at uni.
How are you going at uni?
I'm in my final year. I'm studying science. I normally do pretty well. Last semester I didn't do very well. A bit disappointed. I'm trying to get into honours, so I have to sort of try and focus, work a bit harder.
So Nathan, can I ask you some general questions then?
Yeah, absolutely.
Do you smoke cigarettes?
No, I don't smoke.
And what about alcohol?
I consume a little bit of alcohol sort of every week, but you know, a couple of beers a week.
A couple of beers once a week?
Once a week, yeah, pretty much.
Cannabis?
No, I don't smoke cannabis. I've tried it, but I'm not a regular smoker.
Are you prescribed any medications?
No.
And so you mentioned using ice. How do you take ice?
I normally smoke it with mates.
Have you ever injected drugs?
No, I've never injected drugs.
Good. And so how long have you been smoking ice for?
A couple months now. It's sort of, you know, throughout this year I've really been smoking, but I guess 6-8 months, something like that.
And how often do you do it?
It started off pretty infrequently. I'd say it was about, you know, once a week, a bit less, if that, once a month. But now it's sort of become a bit more frequently. Sometimes, you know, probably every weekend with mates if they're doing it, or with their housemates if we have a big party or something like that. Yeah.
So are you concerned about it increasing?
Well, I mean, when I think about it, I probably have been using it a bit more than I did when I started. I guess that's probably not the best, but yeah, I guess I am using it a bit more than I thought.
And what was the incident you mentioned?
Well, it was a couple of weeks. It was on Sunday, a week ago, and I was out with some mates, and we had a few beers, and then we decided we'd smoke a little bit of ice. And I don't know what happened, but I just completely freaked out. I felt incredibly scared, incredibly anxious. To be honest, it was really horrible. It was terrifying. Thankfully, I called my girlfriend, and she was there, and she came and picked me up and took me to the emergency department.
And what did they say there?
They said I had psychostimulant intoxication, which I guess just meant that I'd taken ice, I don't know. And I had some tests, but then they let me go in the morning after I'd sort of sobered up. But it was, yeah, I mean, that's been the big thing, and Mum found out about that, so that's part of the big reason I'm here.
So Mum's concerned, but I also get a sense that you are worried about what happened, that you didn't enjoy it?
No, because when I first started, it gave me energy, and I've used it also not for recreational. Like I've used it sometimes to get through an all-nighter if I have got like a lab report or something the next day. So I find the energy really nice, but this most recent time I didn't like losing control like that, and there was nothing. I felt completely lost, completely frightened.
you didn't like losing control, you felt frightened. Yeah. So you don't want that to happen again.
No, I don't.
So what do you want to do?
Well, I mean, as we've been talking about it, I think I probably want to try and cut down. I think it's, I think it's stopped being enjoyable in any way, and after that, I never want to have to go back to hospital like that. I don't think I can take that risk. It wouldn't be fair to Mum and the girlfriend.
Have you had occasions where you've not wanted to use, but you've ended up using?
Well, I live with some housemates, and we have some pretty fun parties, and I guess you can get caught up in the moment of a party, and I don't know a lot of the guys who I end up smoking with. They're not my close friends, but they'll come to the parties because my housemates invite them, and then before you know it, I'm high.
So most of your best friends don't use?
No, most of my close friends don't.
Yeah, good. Yeah. So you said cut down. What do you think would be a reasonable aim?
Well, I really want to try and get into honours, and I don't know if it's helping with my studies at all. I mean, I've used it for the all-nighters, but I wonder, the next day I normally feel pretty exhausted and wrecked. And I really want to try to get into honours. So, ideally I'd stop and try and focus on this. I'm not sure though. I mean, it's a bit hard, and as I say, I find myself in those moments, and I get caught up, and before I know it,
So when you first started using it, you were aware of some benefits.
Yes.
What you're saying now is that it's got worse in the sense of using more often, and sometimes using when you don't want to use, and now having some really concerning problems with it.
Yeah.
Yeah.
Yeah, I think that's right.
Yeah. Your girlfriend, what does she think?
She studies. She's really into health and fitness, and just thinks that this is you can't do this and lead a healthy lifestyle. She wants us to be healthy together, and she thinks that after the event at the hospital that led me in the hospital, she told me, I think you have a problem. And that was pretty hard to hear.
And what she thinks matters to you?
It does.
Yeah.
It does.
Yeah. So you'd like to cut down or stop for your concerns, but also because you value the relationship and you think that...
Yeah.
Yeah.
Well, I don't want to be a burden to the people around me.
Yeah.
Yeah.
And your mum and your family?
Yeah, well, she's very, very worried.
Yeah.
Yeah. I mean, she watches the news. She knows how bad it is. She doesn't. Yeah.
Yeah. Good. So, cut down or stop?
Well, I think, try to stop. But I've had some friends who've tried to, and they find it quite difficult. I know that it's quite difficult.
So, what sort of help have they got?
Well, I think they've, part of it is they just recommended coming to a doctor to talk about being open about when you're using and why you're using, and trying to find ways to try to not get into those situations, ideally, or find ways to, when I use it to solve a problem, find other ways to solve that problem, I guess.
So have you noticed anything when you have tried to stop? Have you noticed any problems?
Well, I don't really, I guess I don't think I had as much of a problem, but, I do sort of want it, and on the weekends have got into the mindset of expecting it.
So you crave for it and expect it.
Yeah.
So how do you think you might deal with that?
Well, I'm not quite sure. I mean, I think this is, it feels like I don't have as much control over my own desires. So, yeah, I find that very, very hard.
So is that something you think you could learn to distract yourself from and manage, or do you think... Something
like that. I think so.
Yeah.
Like, I find if I'm with my close friends and they're not using it, normally it doesn't cross my mind as much.
So being with supportive friends rather than using friends helps. Yeah.
I'm going to interrupt you. Thank you. That was an absolutely brilliant job. Gilbert just got up and did that without a script or anything. This is just absolutely fantastic. Really well done. It was really hard for me to interrupt because they're doing such a good job, but I am aware of the time.
Yeah.
But I just, looking at what the interactions that happened there, what did you notice? What things did you think, that was brilliant, I'm going to run on up so that you can actually be heard?
I just thought it was quite educational for us to see motivational interviewing. Every time he did something like that, it would tick off, oh yeah, it was that, oh yeah, it was that. And it's, great.
And that ran for 7 minutes, so it wasn't a huge long time. What else did people notice?
I think the flow was fantastic, and a lot of different stages of how you interacted from one point to the other moved on very fluently. There was a point when I think the discussion was what you want to do from this point onwards. And I think that was the turning point. And at that point, I felt that, what if a patient comes in and they say, doctor, I don't know what to do? At that point, I think we could probably get your input, Dr. Whitton, what would be the best way forward?
Yeah, I think in the stages of change, you're talking about pre-contemplation. So often patients don't want to change. Often they see the benefits of using, and probably if you'd seen Nathan earlier on in his use history, he probably would have told you that it helps him study, it helps him focus, it helps him interact with in a social situation. And sometimes you just have to cut your losses. You might allude to some of the risks. You might say, well, it is a drug of addiction. It can get out of control. It can lead to problems like psychosis, and you can talk about some of the potential risks. But sometimes, particularly in the early stages of drug and alcohol use, the patient actually isn't having any problems. And apart from just sort of making them aware of what problems they might develop, you do just have to be honest and say, well, I'm here. If you do have problems, come back and see me. I don't think it's in your best interest, but I respect you, and leave it at that. I wonder what other people think.
So at the end of the consultation, I realized that is a good consultation, but as a GP, should I refer James to drug and alcohol team?
Sorry?
It is a good consultation, no doubt, but at the end of the consultation, should I refer James to the drug and alcohol team?
Yeah, I think that's where I was trying to get to, because if Nathan can sort this problem out on his own, and my sense was that he was getting pretty close to it, then he doesn't need to see anybody. So, but he might. It might be that he can't stop using in his current situation. He might need to seek counselling support. He might even need to go to a residential withdrawal unit to cope with his withdrawal. So I think that's where you need to get to. Can they do this on their own? Because if a patient can sort the problem out on their own in their own environment, that's the best outcome. But of course, a lot of people with drug dependence are in the predicament that they're in because they can't do that, and they do need additional help, and that's when you need to refer them to other services. Yeah.
I'm sorry, I'm going to move on because I'm aware of the time. If you have questions that you want to ask, I'm going to move on. Sorry, I'm going to move on. Just aware of the time. Just wanted to ask for Nathan as the patient, what was that experience like of that interaction?
I think it was really good because I was sort of allowed to talk through my own thought process and come to true, genuine, reflection and realization on my own. And I think having useful prompting questions like asking about loved ones or people in my life was a useful way of directing that discussion, but also a useful way for me to realize the impact on other people. Because I think if you just had talked about just myself, you might be able to rationalize it a bit more, but at the point you're concerning your mother, you're concerning your girlfriend, and compromising your performance at university and in other things, that's when I think people can start to realize that, the tide has turned. It's no longer providing that positive benefit. And I think it was good to kind of ask me about what I wanted. I think I never felt that I was sort of put upon and made to, being forced to do something. So I never felt resentful, but it felt like the doctor was taking me to a place where I felt like I could, be assisted and be better off.
Fantastic. I want to move on. I know we could spend heaps more time going through that, but thank you, Gilbert. That was really brilliant. Thank you, patient Nathan. Thank you so much. Show the doctor. Okay, so what I want you to do is to do a role play. So this is a person that has come into your practice. Don't show the doctor. They're not supposed to know. It's only for the patient. Only the patients. Doctors do not read the role play. It makes it too easy. Yeah? And the patients will be different. For you guys as patients, think about a patient that you've had that's had these similar problems and just try and live that patient. And as the doctor, very similar to what Gilbert did, really just having those conversations. I'm aware of the time, so I am going to ask you to draw your role play to a close. We have a couple of minutes before we move on to the next speaker. So I just wanted... I'm going to ask someone... Who have I got here? Up the back here. Who's the doctor and who's the patient here? You're the doctor. So it's just everybody... We're going to have a little spot here on this beautiful pair of GPs. You were the doctor in this. How did it go?
Yeah, it's going fine. And my patient is sick now, and it's the exacerbation of pneumonia, and I'm thinking that it may be the side effects of his marijuana using. Yeah.
Was it easy to ask him about the cannabis use? Was it easy? Was it?
Not easy so much, and I was uncomfortable in the beginning, and my patient was cooperative. So. Yeah, it's just going, yeah.
How did she ask? How did she do that?
She is good. She is going question step by step until she reached the definite diagnosis and the definite also about the history. She taking the history step by step until she reached what she want from me and what's the information she want. Without since that I'll give her more information, I was comfortable with his.
So you were comfortable. He thought you did a good job.
Because I'm sick.
I was the patient, and I was with Dr. Malik here, and he did it really well. Because one of the common things that I found with patients is that they often say, well, so-and-so smoked at X amount of years, they're fine. I don't know what the big problem is. And I did that same situation with Dr. Malik, and he just rolled with that really well. And he says, okay, well, what makes you say that? And then we're just focusing on cigarettes. And then he said, he asked me, he goes, look, if it's okay with you, I just want to ask you some other questions about your lifestyle. I said, okay, sure. And then, that's when he started talking about the cannabis use. And even though the cannabis use I was saying was like once a month, right, or once a fortnight, the main focus was just letting me know, like, let's talk about in the future, but let's focus on what you want to do now. So I felt very comfortable talking to Dr. Malik. So it was good.
Fantastic. Anybody else want to make a comment? Anybody find it absolutely excruciatingly hard and never wants to do it again? Yeah, she's over here. She was only joking. I'll pay you later. I'll pay you later. It is hard. It is, and look, and the other thing with role plays is that they're out of context and they're sitting with your colleague, but it is a really good way to just practice skills, and it's a really good being a patient as well and having that experience from the other side around, gee, that person does that really well, or, oh, that didn't quite work for me, so to be able to have those conversations to improve.